Hello, good morning, good afternoon, and good evening to all speakers, chairs, and wonderful audiences in different parts of the world, and welcome to our ACNS webinars. The speakers for the first section today is our honorable guest from Japan, Dr. Kazuaki Yamamoto. Dr. Yamamoto is a distinguished board-certified neurosurgeon and director of functional neurosurgery in the center of Shohan Fujisawa Tokusukai Hospital in Japan. He specialized in stereotactic and functional neurosurgery with a particular focus on the movement disorders such as essential tremors, Parkinson's disease, and dystonia. His clinical and research interests include MRI guided focus ultrasound, deep brain stimulation, RFA, and connectomic neuromodulations. He performs approximately for 200 stereotactic functional surgeries per year, and making him one of the most active neurosurgeons in the field in Japan. He completed clinical and research fellowship in stereotactic and functional neurosurgery at the Toronto Western Hospital of the University of Toronto under the mentorship of Dr. Andres Lozano. He previously trained at the Tokyo Women's Medical University under Dr. Takaomi Taira. He has over 70 peer-reviewed publications and delivered more than 90 invited and conferences presentations worldwide. And we're extremely honored to have him today at our webinar, and today he will share his insight and experience on the application of focus ultrasound for tremors and other neurological conditions. The speaker for the second section of today is our honorable guest from China, Professor Zhao. Professor Zhao is a chief physician associate professor in the neurosurgical department of the Beijing Tiantan Hospital and Capital Medical University, China. He holds the position of the director of Executive Scientific Committee of International Federation of Neuroendoscopy, IFNE, and is a member of Neuroendoscopic Group of Neurosurgery Branch of Beijing Medical Association and member of Neuroplasticity and Functional Reconstruction Group of Brain Tumor Surgery, Special Committee of Neuro Repair of Chinese Medical Association. He is a looked over with several publications in various peer-reviewed journals. We're extremely honored to have him today at our webinar, and today he will be talking about the use of his topic is the surgery and the strategy using the neuroendoport technique and explore the nuances of minimal invasive neuroendoscopy through the neuroendoport system with reduced brain retraction, minimal trauma, and faster recovery. The chair for the first session of today is a distinguished faculty from Italy, Professor Alfonso Francendo. Professor Alfonso is a professor of neurosurgery in the Department of Biomedical Sciences, Humanitas University. And he's also the head of the neurology at IRCCS Humanitas Research Hospitals in Milan, Italy. He is also a professor in the Department of Medicine, Division of Neurosurgery at the University of Toronto. He is a courtesy staff neurologist at the Toronto Western Hospital, University Health Network, at the Hospital of Sick Children in Toronto. Dr. Franceno is a clinician investigator at the Greenville Research Institute and KITE Toronto Rehabilitation Hospital. His main area of interest are the treatment of movement disorder with advanced technology, including infusion pumps and neuromodulation, also the pathologist, and also a pathophysiologist and treatment of tremors and gait disorders. He authored more than 500 scientific papers and book chapters, and we're extremely thankful for him to accepting our invitation to chair the section of Professor Yamamoto. We're extremely honored and grateful to have him today. The chair for the second session is our honorable guest from India, Professor Samir Sinha. Professor Sinha is a principal director and head of neurosurgery at the Max Healthcare Hospital in New Delhi. Dr. Samir Sinha is a reputed and accomplished neurosurgeon who has completed his neurosurgery training from ALL India Institute of Medical Sciences in New Delhi, in India. He comes with extensive experience of 25 years, and Dr. Samir has been trained in spinal surgery and a qualified teaching faculty for the AO Spine, a non-profit organization for the dissemination of knowledge about the spinal pathologies over the world. He's also engaged in various teaching and research activities both in the country and abroad. His primary expertise and interest is minimal access brain and spine surgery, wherein he performed complicated brain and spine surgeries with minimal incisions and with the purpose of less pain and trauma to the patient and early return to the activities. And he's also trained and qualified ATOS trauma faculty, and we're extremely grateful to him for accepting our invitation to chair the session with Professor Jiao Pan. On behalf of the Education Committee of ACNS and President Professor Yoko Kato, I would like to welcome both the speakers and chairs and audiences to this online platform of ACNS webinar, and a farewell welcome to our colleagues in China. We're extremely thankful to Professor Xubing for broadcasting the webinar on the WeChat channel. And Dr. Liu Bunxing from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Alfonso Fasano. Please.
Thank you. Thanks for the invitation to moderate this great program that you put together for today's webinar. And thanks also for the kind introduction, and importantly for giving me the opportunity to introduce the first speaker. I've known Dr. Yamamoto for a while now because of our common work in Toronto, and where he's been trained as a fellow. And I don't think I need to introduce him again, given the fact that you introduced him at the beginning of the webinar. This is just to say that he's absolutely the perfect speaker for this topic, given his role as Director of Functional Neurosurgery. This is about focused ultrasound for Tremor. Is going to give us an update, but importantly, he's also going to discuss where we're going. And this is, I think, a very important topic, because focused ultrasound has been with us for over 12 years at this point. And there's been a lot of exciting news over the past few years. This is a technique that is evolving day by day. And importantly, what's evolving is the indication, how the procedure is done from a technical standpoint, how we are overcoming some barriers that before we had. For example, when we started doing this, we had no idea that one day we'll be doing bilateral surgery. This is to some extent something that has challenged also the framework of functional neurosurgery. For years, we've been saying that lesioning the brain in both hemispheres was too dangerous. And now this is completely revised as a concept. And that's also because of the many technological advances in the field of neuroimaging. So clearly the topic is very timely, and it is important also to acknowledge the limitations of the technique. And I'm sure the speaker will address also the current limitation and how we'll be able to fix or solve these problems in the upcoming years. I don't want to spend too much time talking because we're all eager to hear from the speaker. But I'll certainly be happy to chair the Q&A part, which is following the session. I will urge the attendees and also the other panelists, if they want, the moderator, to take care of, to think about questions, and they can use also the Q&A button at the bottom of the Zoom platform, so that we will go through the question one by one at the end of the presentation. So with this, once again, honored to be with you all, and honored to introduce Dr. Yamamoto. Katsuaki, please, the floor is yours.
Thank you very much, Dr. Fasano. First of all, thank you very much, Professor Kato, for this wonderful opportunity. It is a great honor to be here as an invited speaker at the ACNS webinar. I'm also truly delighted to present under the chairmanship of Professor Fasano, one of the pioneers in the field of movement disorders and stereotechnical functional neurosurgery. Today, I will begin with fundamentals of magnetic resonance guided focused ultrasound, or MRGFUS, briefly reviewing its history and past clinical trials, followed by an overview of ongoing studies, future indications, and emerging perspectives. Oh, these are my disclosures. Well, I intended to introduce myself just briefly, but Dr. Fasano has already introduced me very well, so I'm going to skip this. The magnetic resonance guided focused ultrasound is a relatively new treatment modality in stereotechnical functional neurosurgery. It is primarily used for movement disorders, especially such as tremor and Parkinson tremor. The earliest development of focused ultrasound dates back to 1942. In this photo, a transducer was applied to a cat's skull, and the histology showed a wedge-shaped lesion on the brain surface. In the 1950s, Fry developed a new focused ultrasound system using 4 transducers, enabling convergence of ultrasonic beams in deeper brain regions. In the 1980s, image-guided focus ultrasound emerged, combining beam mode ultrasound imaging for guidance. However, all previous focus ultrasound systems required a craniotomy window. This was because the skull blocks beam mode ultrasound imaging, absorbs ultrasound energy, and introduces phase aberration. Major challenges included visualizing the brain, overcoming reflection and absorption of ultrasound on the surface of the skull, and correcting phase distortion. Technological breakthroughs were needed to overcome these barriers. Later, CT and MRI were introduced for guidance. In figure B here, you can see 3 discrete lesions on the left hemisphere of a dog and a merged lesion on the right, demonstrating how MRI solved the visualization issue. Phase aberration was a particularly challenging issue. Early studies by Fry and Goss in the 1970s showed that ultrasound could be focused, but the focal point was distorted. In the 1990s, phased array transducers and hemispheric designs were developed, allowing phase correction using CT-based skull thickness measurements. This enabled precise focusing despite skull irregularities. This is the most widely used focused ultrasound device today, Exolate Neural by Insightec. The system integrates thermal ablation via high-intensity focused ultrasound, MRI guidance, MR thermometry, and hemispheric array of 1024 transducer elements for phase correction. The principle is similar to burning paper with a magnifying glass. Beams are focused precisely to hit the target tissue. In this image, about 1,000 beam paths are visualized in green. MR thermometry provides near real-time feedback of target temperature during each sonication, shown in the center of this figure. This one. And the procedure includes frame application, imaging, target planning, and treatment. After attaching the frame under local anesthesia, we acquire MRI images, plan the target, and proceed with treatment, which includes alignment, verification, and ablation phases. This video shows 3 treatment phases. First, we check the location of the heated spot with mild temperature increase in the alignment phase. Second, we check therapeutic effects and side effects with a moderate temperature increase in the verification phase. Lastly, we ablate the target with high temperature. For treatment, the head must be completely shaved to avoid cavitation caused by air bubbles. A silicone membrane is applied above the frame like this, which is a CRW frame with MRI-compatible carbon posts. Cavitation is a phenomenon where ultrasound compresses and releases air bubbles. potentially causing tissue damage. This is why shaving and degassed water circulation are essential. Patient is placed in a supine position on an MRI table. The silicone membrane is attached to the transducer unit. This schematic shows a system. Water is filled between the silicone membrane and the transducer unit. It circulates in the system to cool the scalp and the skull to prevent heating. It's also degassed to avoid cavitation. We first acquire whole brain T2-weighted MRI, which is reconstructed into axial, facial, and coronal planes. And see the target on the image. The most common target for essential tremor is the ventral intermediate nucleus of the thalamus, or VIM. There are several methods to set the VIM target. I combine available methods, including indirect targeting based on the anterior commissure and the posterior commissure, anatomical targeting referencing the corticospinal tracts, and tractography, as shown in these figures. Okay, let's move to the treatment stage. Once the target is set and in the planning, we move to the treatment stage and check the skull density ratio that I will explain later. We can also check the skull area, number of active transducer elements, the distribution of skull thickness, and so on. As I have already explained, the energy is increased in a stepwise fashion to increase the target temperatures gradually. In the alignment phase, we need to check the position of the heated spot in all three directions: AP, anterior, posterior, right, left, excuse me, and superior, inferior directions, referring to the MR thermometry. For this, we want temperature around 42 to 46 degrees Celsius. If the heated spot is off the target, we need to adjust the focus. And in the verification phase, we can see therapeutic effects and side effects with target temperature around 47 to 51 degrees Celsius. These effects are reversible in the verification phase. We also check the shape of the heated spot. If the shape is distorted, we can modify the shape using a filter tool bundled in the system. Once the location is confirmed and good clinical effects and absence of side effects, we can move to the treatment phase. In the treatment phase, we ablate the brain tissue with temperature 52 degrees Celsius. Excuse me. With 52 degrees Celsius or over. But we usually want over 54 degrees Celsius to make a good lesion to provide good outcomes. The literature suggests we can perform rapid lesioning with 57 degrees Celsius or over. This is a case of essential tremor to demonstrate improvement in drawing and handwriting. We can see severe kinetic tremor before the procedure. So this is a baseline video in the writing and drawing tasks. This is a day 1 MRI showing an ablative lesion in the left VIM nucleus of the thalamus. Post-procedure examinations show much more stable drawing of the spirals and lines as well as handwriting. Since the patient's tremor improved, he has enjoyed the benefits in his activities of daily living, such as eating, drinking, and dressing. This is a video of a patient with tremor-dominant Parkinson's disease filmed during right VIM thalamotomy. The volume is So you can see the moment that resting tremor in the left upper extremity stops. The ultrasound is being delivered while the lamp is on. Now the ultrasound beams are being delivered. The tremor started to improve, but there is still tremor. There is a little time lag. There is still less tremor. And the tremor is now completely gone. Let's take a look at the RCTs that helped accelerate expansion of MRGFES worldwide. This is an RCT published in 2016. 56 patients with essential tremor underwent focused ultrasound VIM thalamotomy, and 20 patients underwent sham procedures. Improvement in tremor scores was 47% after focused ultrasound and was maintained at 12 months. This is an RCT published in 2017. 20 patients with tremor-dominant Parkinson's disease underwent focused ultrasound VIM thalamotomy, and 7 patients underwent sham procedure. Improvement in tremor scores was 62% after focused ultrasound and was maintained at 12 months. However, I need to clarify that there are patients with difficulty in increasing temperatures in the target. There is a very well-known important factor called skull density ratio, or SDR. It is the ratio between the half-filled units for cortical and marrow bones of the skull. Patients with low skull density ratios are known to be hard to treat. Such cases need higher energy to get treatment temperatures. However, most ultrasonic energy is absorbed on the skull surface in such patients, making it hard for the brain target to reach therapeutic temperatures. The more energy is absorbed on the skull surface, the severer headaches the patients will have. Then, is it impossible to treat patients with low skull density ratios? In the U.S., United States, it is not allowed to treat patients with low SDRs. The FDA of the United States says they can treat patients with SDR of 0.45 plus minus 0.05 technically, or higher. Thus, they cannot treat patients with SDRs lower than 0.4. Why? These figures show the concepts of SDR. Figure A shows that the ultrasound is absorbed or reflects on the surface of the outer table of the skull and between the cortical and marrow bones due to the impedance gaps. Figure B demonstrates a cranium with high skull density ratio where less energy is absorbed or reflects, and more energy passes the skull because of less impedance gaps. Vice versa in figure C, which demonstrates low skull density ratio. Please imagine a soundproof wall. It is just like a cranium with low scalarity ratio. A soundproof wall consists of a spongy material sandwiched by hard materials. It is very efficient to prevent sound from passing. Cranium with low scalarity ratio is similar to this. In the pilot study published by Elias and colleagues in 2013, the term scalar ratio was not used because the concept did not exist at that time. There were patients hard to treat for sure, but nobody knew the reason for that. In the publication in 2016 by Dr. Chen's team, a positive correlation was shown between the SDR and maximum temperature. However, patients with low SDRs are manageable in most cases, even though it is harder to treat such patients compared to those with higher SDRs. There have been some papers indicating the same conclusion. I suppose there are some reasons for this. One is that there are possibly strategies to manage patients with low SDRs. Another is that SDR is not the only factor significantly related to maximum temperature. This is a paper showing factors associated with heating efficiency in MRGFUS. In figure A here, you can see the heating efficiency decreases as the subtotal temperature rise increases. In other words, we can preserve the heating efficiency by minimizing the subtotal temperature rise until the previous sonication. It is ideal to maximize the heating efficiency in the treatment phase to ablate the target with a high temperature. Minimizing temperature rise before ablation will be a strategy to maximize the heating efficiency in low SDR patients. This is another paper demonstrating the concept and discussing similar strategies. There are many advantages of MRGFUS. The effects are immediate and risks of infection and bleeding are low. There is no radiation exposure, no need to implant hardware, and so on. Other advantages include intra-procedural clinical feedback, precise adjustment of the target based on images, real-time, typically near real-time feedback of temperature, and so on. There are multiple stereotactic modalities that we can choose to treat movement disorders. We can provide information about the advantages and disadvantages of each treatment modality to our patients. And they can select the best option according to their conditions and preferences. All right, let's talk about some recent studies. We performed a prospective study of staged bilateral focus ultrasound thalmotomy for essential tremor. The preliminary results suggesting safety and efficacy were published in 2021. A follow-up study compared the bilateral procedures of MRGFUS and deep brain stimulation was published in Movement Disorders 2 months ago. The treatment was significantly effective in both the MRGFUS and DBS cohorts, with no significant differences between the modalities at any time points. A vast majority of focused ultrasound treatments are VIM thalmotomy for patients with essential tremor. Other indications include tremor-dominant Parkinson's disease treated with VIM thalmotomy. There are more targets and indications under investigation. This paper reported non-ET tremor cases treated with MRGFUS. The diagnosis included dystonic tremor in the context of cervical brachial dystonia and writer's cramp. and dystonia gene-associated tremor. This is a study demonstrating the efficacy of cerebellothalamic tractotomy, CTTotomy, with MRGFES for essential tremor patients. It shows a significant improvement in tremor scores at 1 year. This is a unilateral pallidotomy for Parkinson's disease. This study, published in 2021, demonstrated safety and feasibility. However, an RCT published in 2023 revealed that the therapeutic benefits of MRGFES pallidotomy was limited. Subthalamotomy was also performed for Parkinson's disease. The pilot study was published in 2018. And an RCT was published in 2020. Subthalamotomy provided a significant improvement on the MDS-UPDRS Part 3, and the history says we have to be careful about hemipallism after subthalamotomy, but complication rates in this study look lower than those implied in the past. Palliothalamic tractotomy was also trialed in patients with Parkinson's disease. Not only unilateral but also bilateral procedures were performed, and patients experienced a significant improvement on the MDS-UPDRS Part 3. Like palliothalamic tractotomy or DBS targeting the globus pallidus internus. Palliothalamic tractotomy or PTTotomy is also effective in treating dystonia. However, it is not a common indication yet, and MRGFES PTTotomy has not been approved in Japan either. Radiofrequency ablation is the only option to perform it for now. Here are some case demonstrations. This is a 68-year-old violinist presented to my outpatient clinic with treatment-resistant segmental dystonia in the right upper extremity. Her right wrist and elbow flex in every up bow movement. She can conduct the down bow, but the up bow was impossible. She could not play the violin properly after left PTTotomy. So this is day 1. She can now play the violin very well. So here is another case. This is a 61-year-old golfer with dystonia in the right upper extremity. Golfer's dystonia is also known as yips. His swing stopped in the midway before surgery. But the post-op video shows significant improvement. This is after PTTotomy with radiofrequency ablation. A ventrooral thalamotomy or VO thalamotomy is targeting the ventrooral nucleus of the thalamus. Is an option to treat focal dystonia. MRGFUS VO thalamotomy has not been approved in most countries, including Japan. This is a case of a 56-year-old pianist with focal dystonia in the left middle and ring fingers. Those fingers flex while she plays the piano. This is an intraoperative video. You can see that her middle and ring fingers are flexed. During the procedure, she wakes up. Now the electrode is in place, and she feels benefits already. So this is during test simulation. After the ablation, you can see a significant improvement in the left fingers. This shows 1 month after the procedure. You can see significant improvement here. 3 months after the procedure. She says she could not play this piece at all before surgery. MRGFUS with new targets and indications like these procedures is expected to be approved in the future. Other usages of MRGFUS attempts using a focused ultrasound include ablation of brain tumors. Further investigations are needed to assess its effectiveness, utility, and advantages over other treatments. We worked on a study called liquid biopsy. We ablated a part of brain tumors to ablate their exudate, to obtain their exudates for pathological diagnosis by analyzing them in blood samples. There is another way of using focused ultrasound. All the procedures that I talked about today were high-intensity focused ultrasound, or HIFU. The other type of focused ultrasound is low-intensity focused ultrasound, or LIFU. LIFU uses cavitation, the phenomenon that I have already explained today. After the injection of microbubbles, LIFU induces non-harmful cavitation at the target. This technology is used to open blood-brain barrier, or BBB. All trials of BBB opening are still under investigation. This is used for BBB opening in patients with brain tumor. For example, enhanced drug delivery is expected for patients with glioma. The same technology was used for patients with Alzheimer's disease. In addition to enhanced drug delivery, expectations included resorption of the accumulated beta amyloid. A repetitive LIFU was performed in this study, and a decrease in A beta plaques was observed in 4 out of 6 patients. This study was just published in January this year. BBB opening was also trialed for Parkinson's disease dystonia, dementia. BBB opening was performed in 5 patients. No major changes were detected in PET in this study. But again, all these technologies are still under investigation and need further studies. To summarize, the safety and efficacy of MRGFUS VIM thalamotomy are well established for essential tremor and Parkinson's tremor. Other targets for Parkinson's disease are under investigation and may soon gain approval. Application for dystonia with some targets are expected to be approved. High-intensity focused ultrasound may expand to tumor ablation and liquid biopsy. Further studies are needed to evaluate the potential of LIFU, particularly for BBB opening. Thank you very much for your attention.
Thank you. Thank you for the great presentation and for giving us also an overview from a technical standpoint, which is indeed needed given the the use of technology in this type of procedure. There are a few questions in the Q&A, and I think we can address them one by one. Let's start with the first one. If you have someone with Parkinson's with rigidity, what treatment would you do?
Okay, this is a good question. So PD with rigidity rather than a tremor dominant. So it's very important to address. And using the focused ultrasound, I would use paldothalamic tractotomy. However, as I explained in my presentation, it is not approved yet. So there are only two options: paldothalamic tractotomy or paldotomy with radiofrequency ablation or deep brain stimulation. As you know, deep brain stimulation is a good and a reasonable option for disorders like Parkinson's disease, for neurodegenerative and progressive disorders like Parkinson's disease.
Okay. And in your experience, Joe, you have done patients in whom, so actually, I guess people come to you and ask for this treatment without tremor. And what do you usually tell them? You tell them that just is not an option, or it can be tried, or we need to wait and see whether PTT will be approved. What's your approach to patients now when they come with this type of problems?
Very good question. Thank you very much. So of course, I explained about level of a challenge test, and if the patient is a reasonable candidate for surgical procedures, I explained all the pros and cons of radiofrequency ablation versus deep brain stimulation. Because focused ultrasound is not approved, but the patient is in trouble right now. So I always explain all the pros and cons of radiofrequency ablation and deep brain stimulation, and the patients eventually choose which to proceed with.
I see. So you have a conversation with the patient about this.
Yes,
Okay.
exactly.
So the same person is asking some maybe clarification about bilateral thalamotomy. So if you can tell us a bit more how you do it, when you do it.
Okay. I think in the background of this question, this is very important. So there is a very important history. So in the past, bilateral thalamotomy procedures were thought to be dangerous because of high risks of complications. However, when I was in Toronto, we performed staged bilateral focused ultrasound thalamotomy for essential tremor patients, and showed safer outcomes compared to the past. So it means probably it is because the procedures from the past was, those procedures were performed without MRI, and precision and accuracy of those procedures were less than the current methodologies. Recent studies have demonstrated safer outcomes, and bilateral procedures are possible and feasible. So my answer is I do perform bilateral procedures by staged bilateral. First, I performed unilateral thalamotomy using MRGFUS or radiofrequency ablation in most cases after the failure of focused ultrasound without a sufficient temperature increase. And after that, I usually see at least 6 months. So at least 6 months apart, I suggest the second site procedure to my patients.
Yeah, thank you for the clarification. And 6 months is probably the shortest time we can wait, and also to be I mean, more mindful of what's being recommended. For example, the FDA has recommended, it is approved bilateral thalamotomy for tremor, but with an interval of at least 9 months. So I don't know
Yes.
why 9 months in particular they chose, but yes, I agree with you that sometimes 6 months is enough. So that's about the bilateral thalamotomy. Do you have experience with bilateral pallidotomy?
Well, yes, but I wouldn't do bilateral pallidotomy even if it is a staged bilateral nowadays because of the risks of delayed onset infarction. So
Mm.
I switched from pallidotomy to pallidothalamic tracheotomy. The therapeutic outcomes are very similar, but safety is higher, so it's much safer in my experience.
Mhm.
And I never experienced delayed onset infarction after pallidothalamic tracheotomy.
Yeah, I agree. And just to complete on the bilateral topic, I think there's a lot of interest right now with bilateral PTT lesion and a trial that is just being completed, a multi-center
Yes.
trial. We don't have the results yet, but in the design there was also well the idea that I would say almost all participants will go to bilateral PTT lesioning. So we will see, but for sure, as I also indicated in the introduction of your talk. Focus ultrasound has really challenged the idea that lesions can only be done on one hemisphere. So there is an attempt of really going beyond this paradigm. Okay, there is two other questions, and maybe we'll have time for sure for these two, and maybe even for more. Again, Dr. Arshad Parek was asked the other two questions. Is asking an important question, which is the reoccurrence rate. So you do the procedure, the person does well. What happens over time?
Okay, it depends on the indications and the targets. So the recurrence rate after pallidotomy with focus ultrasound for Parkinson's disease is higher than other indications and other targets. Because the laterality is 20 to 21 millimeters from the midline for pallidotomy. So it's too lateral for focus ultrasound. Based on the nature of focus ultrasound, the more medial targets are better. After pallidothalamic tracheotomy, the recurrence rate is much less. I guess further um, studies are required to show that. And in terms of tremor, like essential tremor and Parkinson tremor, so roughly the recurrence rate is around 10%, but it depends on the temperature increase in the patient cohorts. If you treat patients with low SDRs and I mean very very low SDRs like 0.2 something or around, the recurrence rate should be higher, much higher.
Yeah, that's important to know, and it's important also to tell patients and families because they need to know that whatever happens right after surgery might not be the case forever. And the same applies also to adverse events, doesn't it? Because the adverse event technically or hopefully little by little go away, and so there is certainly some plastic changes in the brain going on for the good like effect of on symptoms, but also for the bad side effects. So there's really an evolution over time. So there is another question for you. There is Rezida Galimova who is saying, thank you for the great presentation, Professor Yamamoto. Could you explain more details using filters? So a bit more about the filtering.
Okay, so I think this means filtering tool
Yeah.
in focus ultrasound. So filtering tools reduce the energy or the number of active elements on. So I mean, the ultrasonic beams from coming from lateral sides, from right and left. There are basically two options of filtering tools: binary versus what was it? Reducing the energy. So binary means on or off. So it turns some elements off coming from both sides. And the other type reduces the energy coming from both sides, right and left. And there are three strengths of the filter tools. So like mild, moderate, and a strong one. So, mild filter reduces a small amount of energy coming from both sides, and the high filtering tool reduces a significant amount of energy coming from both sides. And we use it if the shape of the lesion or a heated region in the brain is elongated mediolaterally. So if it is long and oval shape mediolaterally, and the length is too long, and there is a risk of involving the internal capsule or some important structures, we use it to reshape the lesion.
Yeah, thank you. Thanks for the detail. Do you think that this filtering can also help? Well, I guess it does because there has been publication, but maybe you can elaborate a bit more. Doing the focus procedure in people with aneurysm, PLEP, or DBS electrodes implanted.
Yes, but we usually use no pass down region tool to treat patients with cleft aneurysm or other materials implanted in the skull. So I treated some patients like that, and I also treated patients after craniotomy, after clipping an aneurysm. And I used the no Paston region tool. I just drew some circles surrounding the clips, and just to avoid for the ultrasonic beams passing the clips. So we can use it rather than filtering tools.
Mm-hmm. Okay, thank you. We have a few more minutes for questions. I don't know whether the moderator or the other speaker have question for you. I have a few, but I don't know. I want to give the opportunity to the people online to ask more question. If not, in the meantime, I can ask. Oh yeah, they should Mamadili, yeah. Please unmute yourself and you can ask the question.
Hello. Thank you so much for a great presentation. I have a question. How do you measure the temperature inside the brain? Is there some kind of sensor on the ultrasound apparatus or on the skull? I don't know.
Yeah, it's a good question. So it is completely based on the MRI. So it is called the MR thermometry. So based on the signals obtained from MRI, the MR system gives us the temperatures of the different structures in the target. So this is called this is a technology called MR thermometry.
Okay, thank you.
You're welcome.
Anything else from the audience? I have in case, I mean, we have a few more minutes, but let me ask you a question because obviously you practiced in Toronto and you've seen the classic Canadian patients, although even in Canada there is a multicultural society. But I would say in my experience, the approach to this treatment from a patient perspective is more or less homogeneous. So I'm wondering in Japan, so your patients, when they come to you, first of all, do they come with an idea of wanting focus ultrasound? That's why they come to you because they saw it, or they come to you because they have a problem and they want you to fix it. So what the patient and the family have in mind when they come to see you, and also how the conversation goes if they, because you mentioned before they choose, but I'm sure that you also give your input, and also whether these. Well, I'll stop here because I have another question. So, what's your experience in Japan?
Okay, thank you. Thank you for your question. Oh, yeah. It depends on the patients, of course, but there are many patients coming to my clinic hoping for focus ultrasound. And interestingly, there are so many patients who don't want implantation, like deep brain stimulation, and focus ultrasound is a good solution for such patients. But that said, I explain to my patients all the pros and cons of focused ultrasound as well as deep brain stimulation. Um, if the patient's symptoms are rigidity or dyskinesia or bradykinesia rather than a tremor, I explained to my patient that focused ultrasound is not a good option for you, and deep brain stimulation will be better to treat your symptoms. So it depends on the patient's background, of course, the preferences, but also symptoms and else. Like if the patient has, let's say, um, uh, um, um, something like diabetes mellitus or something, and a patient has high risks of infection. I always explain to my patients about the risks of implantation. And even if the patients want to proceed with deep brain stimulation in such cases, um, I explain to my patient that focused ultrasound is also a good option for you. So it depends on the background and something else.
Understand. Yeah, it's always a personalized approach. And the other question I was about to ask is whether you've noticed that now that there is another option, particular focused ultrasound, if you're doing more DBS or you're doing more radio frequency lesioning because people are more interested to be treated.
Yeah, so without skin incision, first comes a question comes to me like, is it possible to treat my tremor without cutting the skin or making a borehole? So such patients usually want to proceed with focused ultrasound. Oh, because I think they know it's less invasive, and they don't usually don't want to proceed with the implantation procedure. So I explained that this is still surgery, and I'm gonna ablate a part of your brain, but it is true that you don't need any skin incision or borehole for this procedure. But you still have a risk of complications, and there is a risk of that the patient's target doesn't reach sufficient temperature. And in such cases, like we did in Toronto, radiofrequency ablation is also an option for such patients after failure of focused ultrasound.
Yeah, that's the experience in Toronto as well, that there's more or less more interest and more procedures. And our job is to match the right candidate with the right procedure. Very good. Thank you, Kaswaki. It's been really a pleasure to moderate your session, to listen to your lecture. We are a little bit well early because it's 29 minutes past the hour, but I think it doesn't hurt if we give this minute back to the moderator so that we can to the next session so that we can hear the next talk. So thank you once again, and thanks everybody for tuning in and for the opportunity to be moderating this session.
Thank you
Thank
very
you.
much.
Bye.
Thank you. Thank you so much. And indeed, thank you so much, Professor Alfonso, for your sharing, and also Dr. Yamamoto for your great presentations. So since there is a news with the professor submit that he could not join us today because of he's having an emergency keeping cases. And so I will take this chance to introduce our honorable guest from China, Professor Zhao Pang. Professor Pang is the chief physician and associate professor in the neurosurgical department of the Beijing Tintan Hospital in the Capital Medical Center, Medical University of China. And he holds the position of the director of executive scientific committee of in the National Federation of Neuroendoscopy, IFNE, and he's a member of the neuroendoscopic group of the neurosurgery branch of the Beijing Medical Association and member of the neuroplasticity and functional reconstruction group for brain tumor surgery, and also the special committee for neuro repair of Chinese Medical Association. And he also published a lot of publications. And personally, I know him very indeed, and he's a good friend of us. And he's very experienced in endoscopic skull-based surgery, and also the in brain tumors surgeries. So today, his topic will be intraventricular tumor surgery and strategy using the neuroendoport technique, explore the neurosystems of minimally invasive neuroendoscopy through the neuroendoport system with reduced brain retraction, trauma, and faster recovery. Joe, please share your slide.
Okay, and many thanks for Ben for the introduction of myself. We are very good friends in China so many times. And first, let me to thank you for the Professor Kato. And just I will introduce for the introduction. Today, I just present the intraventricular tumor surgery and strategy analysis by neuroendoport technique, advantage and disadvantage. I'm Dr. Zhao from Beijing Tiantan Hospital. As you know, endoscope endoport technology is a technique for performing intracranial surgery through minimally invasive channels, using endoscope and special instruments to reduce damage to the brain tissue, improve surgical accuracy. Traditional surgery has significant trauma, slow recovery, and is prone to complications. Endoscope endoport technology has gradually become a new choice for treatment of ventricular tumors. So nowadays we do some cases use this technique. As you know, use endoscopes and a special instrument to enter the ventricle system through a small incision, and achieving a resection and a clear field of view. The process includes the positioning and the puncture, channel establishment, and the endoscopic insertion and lesion removal, and so on. Also, we use the high definition endoscope and see the tumor very clear. Nowadays, we perform endoport technology use tubular system. This slide shows our tubular system. The advantage is soft retraction and flexible expansion and less retraction of the brain. The deep lesion can be seen clearly. And after removing the tube, and the brain can be protected very well. I show you the insertion process here. First, we just with this needle to puncture the ventricle, and with this balloon for dilation. This is a balloon dilation. It's just a soft retraction of the brain, no brain tissue removal, and then with the endoport to insert into the ventricle, and then remove the tumor step by step. And after remove this channel, we can see the brain just shrink to the very small, less distance. So from the reference, nowadays the use the tubular retractor system can be recurrent very well. the total resection rate can be more than 80.6%, more than the traditional procedure. Also, the complication rate is reduced to 10.9%. So nowadays, we also use this is a visual underpod. Now it's made by Chinese, China market. So this is we just use this endoscope insert into this insertion needle, and then dilation. This is a total system. We can see here. This is the video shows you after the brain. This is the puncture site, and we use the underpod to see clearly into the ventricle. You can see this is a white matter. After resection, the step by step, you can find that this part is just the first puncture needle here, and then we can see in the ventricle. So this is maybe similar with the navigation. This is we call the visual endopod. It's very, very useful for the puncture to the ventricle. Also, the advantage of endoscope endopod I summarize here is that just for the minimal trauma and the patient can recover very well. Also, the clear field of view and the precise resection of the tumor, we use the using the endoscope. Also, we can preserve the neural function. We just here show you the clinical materials of our cases. We have from the 2018 to 2024, we performed 55 cases only for the intraventricular tumor and undergoing the endoscope endopod surgery. And also the patient recovered very well. The location of the tumor include the right ventricle, left ventricle, third ventricle. All here I summarized in this timetable, this table. Also, the patient, all the operation duration is within the 4 hours, and more than 15 cases, 50% of patients undergoing fistula surgery simultaneously, all with the ETV. It's just use the endoscope. This slide show you the result of our clinical data. The complication of the mainly is infection, epileptic seizures, and postoperative hemorrhage and hydrocephalus. And the neurological impairment is very less, and no deaths in our group. This is the result of our group. Also, we can have a high resection rate and a good prognosis. Within our group, we have the 80% of patients of total resection, and almost all the cases subtotal total resection of the tumor. Also, all the patients recovered very well. Nowadays, we just with all these patients with following up. Now I show you some cases of our just endopod technique. This is the first case is the male 60 years old. The lesion is a location in the right lateral ventricle side here. Just from the preoperative MRI, we can find the tumor here, and then we the patient location, the position, and I show you this video here. We can see after just insert the endopod, we can find the tumor on the mono the foramen, and then we remove the tumor piece by piece. The basement of the tumor is on the septum. We just remove the tumor gently, protect the septum vein here. Here, I remove the tumor. And also, I use the septostomy. I just said to you, we can find the other side of ventricle, this left ventricle here. This is the right ventricle, the manual foramen, all the tumor removed very well. Also, this is the post-operative MRI scan, the tumor removed very well. And this pathology is subependymoma. The second case is a lesion in the intraventricular foramen of lateral ventricle. From the preoperative MRI scan, we can find the tumor here. The diagnosis, preoperative diagnosis is a cavernous hemangioma. Is also a common disease on the ventricle. Here, I show you the video here. After insertion of the endopod, we find the tumor is located on at the foramen. Here, this is septal vein. This is plexus. Also, this is the thalamic vein. And just remove the lesion from the frontal hall of the morphomen front, and protect all the structures. After remove this cavernous hemangioma, we just enter into the third ventricle. The deep is the third ventricle. After operation, the patient the name recovered well, no paralysis. The third case is a male, 23 years old. It's a very common disease in the ventricle. It's a giant central neurocytoma. From the preoperative CT scan, we can find the tumor almost in the right ventricle, also with the calcification. From the preoperative MRI scan, we find the tumor enlarged in the ventricle site, also has the hydrocephalus. So I remove the tumor using endopod technique. After inserting into the endopod technique into the ventricle, we find the tumor here. We remove the tumors piece by piece. I just called this kind of central neurocytoma, just like pituitary adenoma. Can you see here? It's a green matter, but it's a full blood. So remove the frontal hall of the tumor. We find the markers. This is the lateral side of ventricle, and this is normal ventricle. So if you do the operation in the ventricle, you must locate the marker. It's very important, because the small incision and the small endopod, if you can lost the way. So the confirm the position is very important. Location is very important. Sometimes I use the curved section and the curved calculation to maybe the posterior hall of ventricle. And also I just swing the endopod, just gently swing to the post hall. After remove the tumor, we find the normal structures. This is plexus, so the tumor removed very well. The post-operative MRI scan, we can find the tumor removed very well. The patient discharged 7 days, no lumbar puncture. It's an amazing case. So all our colleagues said this is a very promising technique. The fourth case is also another giant neurocytoma. From the preoperative MRI scan, we can find the tumor almost in the left and the right ventricles here. From the frontal hall to the posterior hall of ventricle, almost on the left ventricle. So this is the patient positioning. Nowadays, I use this holder. It's made by Chinese market. It's very small, and it can hold the endopod very fixed. No removing. Okay, and also I show you this case in this video. After puncture to the ventricle, I insert the endopod into the endopod into the ventricle, and I just fix the endoscope and remove the tumor piece by piece. Last case, I said that this kind of central neurocytoma is like pituitary adenoma. This is the green matter, and then remove the tumor frontal hall. Quickly find the normal markers here. This is the wall of ventricle here. This is the wall of ventricle, and then I just swing the endopod to the posterior hall of the ventricle to remove the posterior part of the tumor here. This is the plexus from the moral foramen to the temporal hall of the ventricle. This is thalamic area, so be careful about the thalamic area. It can injure the thalamic anatomy. So after remove all the tumor, I just find every part of it has the remnant of tumor and coagulate any bleeding. Okay, with irrigation and all the tumor removed very well, I just retract this endpot. I show you here. It's a very small hole of the endpot after removing, and then I just use a very small the surgery cell to fold the last part of operation. So we can see this is post-operative MRI scan. The case this is the case the tumor removed very well. The patient no limb damage, and the pathology is also the central neurocytoma. Okay, and another case is just another is epidermoid cyst in the ventricle, in the left ventricle, is almost from all the ventricle side. From the preoperative MRI scan, we can find the DWI is a high signal, so the diagnosis is no problem with the epidermoid cyst. Also, I use endpot technique to remove the tumor. After insert, I show you this. After insert the endpot, I dilate the brain, and then I show you this technique is very easy and simple to puncture the ventricle and insert the endpot and fix the endoscope and then remove the tumor piece by piece. Just be careful about the membrane of this epidermoid cyst. It's a very small, maybe small tissue, small artery on the membrane. Calculate this blood supply. Also, I use this curved suction of a curved calculate the bipolar. It's just very use way to using in the endpot technique. Then I remove the tumor very totally and gently remove the endpot. Then this is the total view of the surgical area, no bleeding, and protected very well. This is the post-operative MRI scan. We find that the tumor removed very well, and also the pathology is epidermoid cyst. Another case is another common disease in the ventricle is also in the temporal hall of the ventricle. It's a meningioma. So I also use this endoscope technique to remove the tumor. Just a very small dural opening with balloon dilation and insert the endopot. Just first, I just remove a small part of the tumor, and then find the blood supply. As you know, this kind of meningioma, the blood supply is in the deep of the plexus, maybe plexus artery. So after we just find the area and space, we make a small space into the deep, and then I just use the endoscope to near deep the artery supply. Just you see, I just calculate here. This is blood supply because endoscope can be very near to see. This is the blood supply. I calculate the blood supply here. This is that's different from the microscope. Some doctors, some professor do the use the microscope, but he cannot see clearly the deep blood supply. Just remove the tumor first, the upper part of the tumor. But we use endoscope, we can just find this blood supply very clear. Just calculate the blood supply, and then cut the blood supply here. And I can remove the tumor totally. So we can see here all the anatomy is very well, no damage, no bleeding, and also I have no just the material to put here. So I remove the underpart at the last part. Okay. So the post-operative MR scan, we can see the tumor removed very well, and also the patient recovered very well. And the last case I show you is a intraventricular hemorrhage. This is very popular in China for underpart technique, use the endoscope nowadays. So first, this is a CT scan, all the hematoma in the ventricle. So I use this underpart. It's very, very simple, and it's much more simple than the tumor removal. After remove the hematoma, small and here, and also I see in the left ventricle the hematoma removed very well, but here is a small, just the small part of the hematoma. So I use the section to remove this small this small part of hematoma here. We can see the aqueduct here. So the CSF circulation has no problem. So this is the post-operative CT scan. We can find the hematoma removed very well. The patient discharged as regular. So now the advantage of endoscope and the powder technology from the literature, we can find here the precise positioning and the circulation of CSF is recovered very well. Also, we use endoscope, the lightening and the distance. And also, I just find some advantage of this kind of disease technique. Here, because this is the neuroendoscopy and part precise positioning from the frontal hall, the midline approach. I also the temporal hall. I can use underpart everywhere from the front to the post part of the ventricle, no problem. Also, some doctors said to me, use the underpart swing range. Swing range is some difficult, but because the white matter is longitudinal, so the range and angle of movement of underpart is within a controllable range. From the right frontal angle to the temporal hall is no problem, but accurately control of swing range of the neural underpart according to the surgical requirement. Avoid excessive swing range causing damage of surrounding tissue, while ensuring about the swing range is within a small enough to provide precise and surgical precision. As you see, I can use from the front hall to the temporal hall. It's no problem. I show you this. You can find after the tumor removing, and then this is the front hole here, the monoforamen. So this is the front hall, and also I swing. This is the temporal hall. This is the plexus, the temporal plexus. So from the front to the temporal is no problem. I think this underpart swing range is no problem. Also, we can get a clear lightening and the distance of visible for this kind of technique. And so after, we can see very clear this, because this endport is we can find the outside of the ventricle. If there's some bleeding, we can coagulate simultaneously. It will provide a better lightening. Okay. Also, we can get a reconstruction of the CSF circulation. So just I show you this case. After removing the tumor, we find that this is the monoforamen, but we must find the CSF circulation is very well here. This is the aqueduct. So after you find this place, you can just confirm the CSF circulation is no problem. It will just avoid hydrocephalus in the future. Also, the selection of the ostomy channel is very important because we use a very small incision. I use a soft dilation, no brain tissue removal So I think this channel can shrink very quick. So from this is I confirm I compare with microscope surgery. The 3 months after operation, we can see the microsurgery the channel here. But after this is the neuroendoscope and port technique, the channel just is disappear. Okay, so I think this ostomy is a advantage for the underport technique. But also there are some disadvantage of underport technique. I show you here. Surgical bleeding is important and is a must just be careful. I show you this case. Just you see from here, after remove the tumor, I find the deep site is a very, very important vein. I cannot coagulate any vein, but also a small bleeding here that I try to coagulate. And after the coagulation, there is no bleeding. At last, just I finish operation, but it's not confirmed. But after a CT scan, we can find also there's some bleeding. So because with the underport is very small, the small channel, the small field of view. So this also very important that anatomy in the ventricle. So the bleeding, the stop coagulation is must be careful. Another situation is just the channel bleeding. Here we can find after remove the tumor, we find that the outside is some small bleeding outside the underport. I coagulate, and after remove this underport, I also find no bleeding. But after operation, you can find here the channel. This is after operation, we can find the channel also there's some bleeding. Okay, so maybe this is another disadvantage of this technique, because outside we just careful protect, but also there are some cases bleeding outside. So I think the strategy for this hemostasis is very important. The accurate hemostasis is most important. Also, another case is thalamic injury, because outside this case we find that here is the tumor location is a recurrent central cytoma. Here I show you the video. The tumor is just at the thalamic area. Here the thalamic, I just dissect from the thalamic and protect the thalamic area. Here, just this is tumor, this is thalamic. There is a very small artery, blood supply to the tumor. I coagulate very gently, protect the area, because we can use the endoscope clear view of this, and just very near the site, find that there's some bleeding or the artery. Here, very small artery, I can calculate directly. But after operation, this left side, the thalamic is some small infection. The patient here, the state. Also, I just I do the VP shunt because of hydrocephalus. But the patient now recovery just with the normal site. So the thalamic damage is very important. Also, you must be careful. So new underport technique future include technology innovation, and AI also can use in this technique. I use this the free. This is the freeholder. It's very small. I think it can do operation very well. Also in our group, we have a very good group. Yeah, I can do this operation with very successful view. So now this come to the conclusion. Just I think the advantage of an endoscope and the port technology is a minimally trauma and a faster recovery of the patient and the precise resection of the ventricle tumors. Also, it can improve the treatment efficiency of patient quality life. Also, we will use optimize the surgical process and then reduce the surgical risks in the future. This is our published paper. Now I do some work in the international. I just create a China, US, and Italy training center with our Professor Zhang and Professor Gui and Professor Li. We just with the Italy, the Professor Cabianca and Cavallo is very good friends. Also, Professor Sinali. Nowadays, this year, I just attend the evening workshop with Professor and this Italy Professor Sinali. We have good communication. Thank you for all.
Thank you so much, Professor Joe, and really excellent lectures. So, are there any comments or questions from the floor? So there are some questions in the chat box. So the first question is by Esma Nero, who is asking, what is the size of the intraventricular tumor suitable for this technique?
Okay, it's a good question. So the question is just what the size of intraventricular tumor suitable. I think maybe in my cases, I have do the nowadays more than 60 cases of the ventricle, from the smaller, maybe 1 centimeter, to the larger 5 or 6, maybe 7 centimeter. All the size I do use underport in the ventricle. But I think the suitable side maybe has no dangerous or more suitable, more simple is a small tumor. Small, maybe 1 or 2 centimeter. I do maybe the subependymoma, just like you see the first case. I do this, I remove the tumor only 10 minutes. After insertion and remove the tumor, just you see this the video. Just 5 minutes remove the tumor. It's very quick. So I think 1 or maybe 1 or 2 centimeter is very suitable for the underport technique. But as for the large cases, it's no problem. I think the most important problem or questions for this kind of technique is the tumor, just the quality. You know, every tumor, if the soft tumor, it can remove very gently and very just comfortable for the doctors. But if the tumor is very hard, and maybe if you can not just suction piece by piece, must use scissors to cut piece by piece, is difficult. So if the large tumor and with the softer quality, no problem. Also use this underport, you can do very well. So I think the size and the quality for this kind of tumor is all similar important.
Okay. We have one raised hand from Professor Poon from our hospital. And Professor Poon, any comments?
Hello, can you hear me?
Yes.
Hi, Professor Zhao. I'm Poon from Queen Elizabeth Hospital from Hong Kong, working with Ben together. So I enjoy your lecture very much. You showed all those successful cases in your adult patients. Have you tried those endoport in pediatric cases? Do you think whether there might be some difference between adult and pediatric brain when you put the endoport?
It's a good question. So for I do the underport in the just for the young adult. No problem. This not for the underport and it's limited to underport, because we use the underport only. My underport is 2 centimeter diameter, so I insert in the underport into the ventricle, and I can remove the tumor in the ventricle very fluently. It's not according to the age of a patient. For I show you in my slide. I summarize my cases. I have the young adult cases, so no problem. I think it's no problem because underport is no limited for the ages for the age.
Thank you very much. We hope we can soon have more chances to introduce this endoport for our patients for more collaboration with your center. Thank you.
Okay, thank you.
Thank you so much, Dr. Poon. And the next question is from Dr. Harshit. So do you have any experience to try this endoport technique in intraaxial lesions like tumors or hematoma that is inside the brain, if the lesion is inside the brain, not in the ventricle, inside the brain?
Okay. I just understand these questions. He want to know not the lesion in the ventricle, outside the ventricle, in the brain.
In the brain,
no
yes.
problem. I do this underport use, the glioma. Glioma can use this kind of underport because if you insert into the lesion and just use the maybe bipolar and a backhand technique, bipolar and the suction, every tumor you can use this underport. I think no problem. Because if you just familiar with endoscope, you use endoscope to skull base. Any disease in the brain, you can do it use endoport. So sometimes here I just said to my student, I every day I just do some skull-based disease with the transnasal approach. I said to them, nasal is an endoport. Do you think so? It's a two endoport. And if brain has two endoport, you can with one with the endoscope, another with suction, who into the brain. It's the same. So I think skull base use the transnasal approach. It's another kind of underport technique because this nose is a natural underport. So I think the brain disease in the astral you can use underport, no problem. I have invited one professor from the Australia professor. I forgot his name. He just show you one PPT. Also use the deep glioma use underport. This Australia professor. Just he do operation from the in the deep side. He use underport 30 years ago. I think it's no problem. He do the cases very well. So at that time, I know the underport technique. But for the ventricle tumors, I think because it has the natural space, because the ventricle after the CSF remove out all the normal anatomy, you can see clearly, and also can protect the normal anatomy. So this is very suitable for underport. Okay.
I see. And another question is in small ventricles and or in the endoport surgery, do you use the levitation?
Oh, this is a common. That's just a common questions. Every webinar or every meetings, some doctors asked me if you use navigation. I think I use a navigation sometime. It's just my common answers. But nowadays I do not use navigation. If the ventricle you use CSF after the CSF just out, it will remove. The navigation has some mistake, so no problem, no use. You must use your idea, your mind to locate the tumor. Some doctors said to me, because the ventricle is fixed, and no problem, you can use the navigation. But I just said in my presentation, if you have the anatomy of ventricle, after you puncture into the ventricle, you must locate your place. So find your normal, just your normal place is very important, normal marker, because the tumor in the ventricle, all the normal anatomy just change. So find the normal anatomy is very important. So I just show you the video. I remove the frontal part of the tumor and find the septum, the lateral ventricle. It's a normal anatomy. After the normal anatomy appear, you can confirm. Okay, this is important. Navigation just can help you, and you are the first. You are the first choice. Your anatomy in your mind. Okay.
How about is it necessary to put a EVD, the external ventricular drain, after every surgery for if you open the ventricle?
In my case, I have no EVD. Because just as I show you, the advantage of my technique is CSF circulation recovery. I said to all the audience, this is endoscope advantage. Endoscope can recover the CSF circulation. Because we have this, we can see clearly aqueduct, the third ventricle bottom. Okay, and maybe you can find this plexus very well. So after you remove the tumor, you can do ETV, you can do septum ostomy, okay, and you can find the plexus, the colloid plexus, the way you can find. So no EVD. If I think these professors want to know, if you do not do the EVD in the future, maybe there has some hydrocephalus. But if you simultaneously remove the tumor and you recover the CSF circulation, why do you use EVD? No. So in my case, I have no EVD. No problem. But sometimes my younger colleagues said to me, you can put just the tube inside, but no with the after operation you just close it. Okay, sometimes I do that, but the second day after operation I almost remove. So no use EVD.
I see. That's interesting. So I think we have the time for the last question. Is there are some audiences that they want to learn about this technique. So how can they learn? Is there any courses?
Okay, we have courses. Are no special courses, but in maybe 1 year or 2 times we have skill-based training course in our hospital, my ward, and I will show all the attending about this technique, my presentation and what I can do, and I also show them my experience. So if the other audience want to learn, you can maybe contact with Ben or me and to my hospital to learn this technique. Okay.
Sure, and maybe if you have the details for your courses, you can send it to me, and I can share to the ACNS group. to promote it.
Okay. Thank you. Thank you. Thank you.
And Liu, any comment from you?
No question from me.
Okay. Thank you so much. So I think we have a very fruitful discussion today, and I think it comes to the end of our webinars today. So I really appreciate to all these chair speakers and also the moderator and also the audiences. And so on behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Dr. Kazuaki Yamamoto and Professor Zhao Pang, as well as the chairs, Professor Alfonso Fanceno, for the time and the support for the ACNS webinars. A special thanks to Professor Xu Bin for broadcasting this webinar on the WeChat channel. So today we have around 540 audiences today. And a special thanks to my co-host Liu Bunxing for joining me today. So until we all meet online tomorrow, is bye-bye for all of us. And thank you so much for joining.